We base our recommendations upon either the symptom that the patient had or their cancer treatment. But there's so many other things that modify their risk, whatever their genetic makeup might be. So now we're starting to see different genetic factors that actually increase risk in some areas or decrease risk in other areas. Or we better understand how environmental exposures affect a cancer survivor. So if you have somebody that had a head and neck cancer and they continue to smoke, what's the risk of lung cancer? Or if you have a Hodgkin lymphoma survivor that had chest radiation and they smoke, what's the risk of lung cancer? So we're better understanding those environmental factors, those genetic factors, and then the last thing is comorbidities. So if somebody has hypertension before they have an anthracycline, what does that do for the risk of having heart disease or heart failure? And as you put all of those together, we are in the midst of making prediction models, prediction tools, so that we can better individualize it. You can put the genetic components into it, you can put into the environmental exposures, you can put into the treatment exposures, you can put in the comorbidities, and that will give you a better sense of who needs what when. So rather than saying everybody needs a certain test at age 35 or 10 years after therapy, now you can say this population of patients are going to benefit more from it, and this population of patients benefit less, even though they might have all had the same exposure. So it's a much more personalized, precision, if you will, approach.